Hi friends, I'm Dr. Mayur Kulkarni, your radiology faculty, and here we meet again, this time to discuss the recently asked radiology related questions in your INI-CET May 2023 exam. Now, mind you, this particular exam was an atypically typical exam. What was atypical about this exam was that the number of questions which are directly related to the previous year questions, right? So previous year questions, the repetition part of the previous year questions was actually significantly less as compared to what was expected going by the trend of the last few exams. Though this was the atypical part, the very typical part about very typical aspect about this particular exam was that though the exact repetition of previous year questions was not seen, the topics on which questions were asked were actually those which were expected, right? So there were a few questions on antenatal obstetric ultrasound. There were two questions on hepatobiliary imaging, right? So hepatobiliary imaging, so many questions have already been asked in your INI-CET exams. Same was the case with this particular exam as well. There was a question on chest X-ray basics. There were a few trauma related questions, right? So let us jump into the discussion of these particular questions. Let us start with the first question here. The question is, which of the following is not an advantage of USG over mammography? So, because they are asking you a comparison of mammography and USG, right? This is a question pertaining to basically breast imaging. So, in breast imaging, right, the question is about the comparative advantages of USG over mammography. It is useful. So, which of these is not an advantage of USG? It is useful in young females with dense breast, differentiates between solid and cystic lesions of the breast, guided biopsy can be done, or can USG be used for mammographically undetectable but and clinically non-palpable breast mass? Let us explore these options a little bit. When we think of breast imaging, we consider three main modalities: mammography, ultrasound, and MRI. What is the role of these modalities? Remember, mammography is the screening. Mammography is the screening investigation of choice. Now, if you see the word screening in your question, remember that the answer is usually mammography. There are some exceptions to this rule though, and we are going to discuss that as we go ahead. If you don't see the word screening, and if they ask you what is the overall best imaging investigation of choice, then the overall best imaging investigation of choice is MRI. So the overall best or imaging investigation of choice is MRI. A specific type of MRI is done in the breast imaging. What is that? We have discussed this in our routine videos. What is the type of MRI? It is called dynamic contrast enhanced MRI, where various contrast enhancement pattern curves are plotted, and based on these curves, the final diagnosis of a benign, indeterminate, or a malignant lesion can be made. Now, on one side, we have discussed screening investigation of choices, mammography, overall best imaging investigation of choices, MRI, dynamic contrast enhanced MRI. What is the role of ultrasound then? Remember, ultrasound serves more like a problem solving modality. Whenever there is a problem, right, we take the help of ultrasound. Does ultrasound have any screening role, right, in breast imaging? The answer is no. So ultrasound has no screening role for breast cancer. So let us explore this in a little bit more detail and discuss a few things about these modalities. Let us start with the comparison of mammography versus ultrasound. As far as the patient characteristics is concerned, what about the age? Now remember, mammography, is particularly suited for patients who are middle-aged, or elderly. Whereas ultrasound is for breast imaging, ultrasound is usually best suited for young patients. Why is it so? Because with age, the density of the breast changes. Age has an inverse relationship with breast density, which means that as age increases, the breast density decreases. And therefore, mammography is best suited for middle-aged or elderly patients who have a low breast density. In fact, on mammography, remember, breast based on its imaging characteristics on mammography can be classified into 4 types based on its density. These are called types A, B, C, and D. Type A breast density is predominantly fatty breast density. Breast tissue comprises of what? So breast tissue basically comprises of fat and fibroglandular tissue, right? Type A breasts are predominantly fatty, so they are less dense. Type B breasts, as far as the type of breast based on the density on mammography, type B breasts have few scattered fibroglandular elements, few scattered fibroglandular components. Type C breasts are those that are moderately dense, whereas type D breasts on mammography are those that are extremely dense, that is predominantly uh, glandular tissue or fibroglandular tissue is maximum. So based on density, breasts can be on mammography can be classified into 4 types. We've just discussed that. Now, mammography is best suited for middle-aged to elderly patients with a low density, right? Which have a low density. On the other hand, ultrasound is best suited for young patients, and we have discussed that age is inversely related to density. So young patients usually have a high density of the breast, right? So mammography is suited for middle-aged to elderly with low density breasts, whereas ultrasound is suited for young patients with high density of the breasts, right? So to summarize, we have just discussed mammography is used predominantly in the middle-aged to elderly patients, that is those which have a low density breasts, whereas ultrasound is best suited for young patients with high density breasts. Right now, let us look at a few cases that will also help us compare mammography and ultrasound and its advantages and disadvantages. So look at this case one. This is a mammography image, and on this mammography image, right, this is a craniocaudal view. So this is the outer quadrant, right, this is the inner quadrant. You can see a well defined oval lesion in the outer quadrant of the right breast here. It is wider than it is taller. It has smooth margins with only few lobulations. It has no spiculations. These are all the characteristics that we usually use in BIRADS. This looks predominantly like a benign breast lesion. Look at case number 2, right? Again, a craniocaudal, mammogram image. This is the outer quadrant. This is the inner quadrant of the right breast. Again, can you see a similar lesion? It is again oval, smooth, well-defined margins, very few lobulations, no spiculations. So don't you think both these lesions look quite similar? So when we did a further ultrasound of these lesions, in the first case, we found this particular lesion to be an anechoic lesion on ultrasound. So this is a jet black anechoic lesion. The diagnosis was a simple cyst within the breast. Whereas in the second lesion, when we did an ultrasound, the lesion was not cystic, it was solid, right? It was hypoechoic, solid appearing lesion, right? With posterior acoustic enhancement. So based on this appearance, this was the most common benign lesion which is found in the breast. And what is that? This was diagnosed as a case of fibroadenoma. So, don't you think both of these lesions actually looked quite similar on mammography, right? But when we did an ultrasound, it was ultrasound which actually helped us to determine whether the lesion is a cystic lesion or it is a solid lesion. That is another advantage of ultrasound over mammography. We have just illustrated that in this particular clinical example. Now, let us come back to this question. Which of the following is not an advantage of USG over mammography? USG is useful in young females with a dense breast is definitely an advantage. We have discussed that as to when and how we use these modalities, right? USG helps us to differentiate between solid and cystic lesions of the breast. We just discussed this with the help of an example, right? USG can be used for guided biopsies is true. Remember, the biggest advantage of ultrasound as a modality is that it is a real-time dynamic imaging modality. So when you introduce a needle into the breast tissue, you can track that needle real time as to where is it traveling. You can therefore introduce it, direct it so that it enters into a breast lesion. You can verify, you can cross-check by slightly moving the needle whether the tip is really within that particular lesion, and then you can do a biopsy or a fine needle aspiration cytology. This is one of the biggest advantage of ultrasound, that is, it is a real-time imaging modality. Now let us look at the last option. Ultrasound can be used for mammographically undetectable, clinically non-palpable breast mass, right? So a lesion is not palpable clinically, it is not seen on mammography, yet it can be seen on ultrasound. Based on the options which are available here, right, this last option appears to be the answer to this question, right? If I relate this to the experience that I have in clinical imaging, and also having spoken to many of my colleagues who work exclusively with breast imaging, they have said that this last statement could also be partly true. In some special situations, if the breast lesion is very small, so small lesions within the breasts can sometimes can sometimes not be detected on clinical examination, so they are not clinically palpable. Because they are small, they may be overlapped or hidden by the fibroglandular tissue, so they might not be visible on mammography as well, and ultrasound then successfully helps us to detect them, though the proportion of such cases is very small, right? So what I'm saying is that though I told you that the answer to this question is D, right, this is not a definite advantage. In some special situations it can prove out to be an advantage, right? So here really in these available options, maybe in the recall that students really remember, if this D option could have been framed a little bit more differently, right, the answer would change. In these available options, right, here in the exam, the best possible answer we are going to choose here is D, because this is a very, very small proportion of cases in which it works, whereas A, B, and C are definitely prominent and significant advantages of ultrasound over mammography. I hope you get this. Let us now move on to a few important topics related to breast imaging before we jump to the next topic. So when do you do mammography for screening? Which modalities do you use? A very frequently asked question. The discussion that we are going to have is going based on the American Society of Breast Surgeons recommendations dated 2019. So formal clinical risk assessment needs to be done at 25 years of age. This is where the patient is examined, a detailed history is taken, and the patient is divided into 3 risk categories based on these examination findings. Now, before we go to these categories, remember it this way, just remember the numbers 25, 30, 35 and 40. So 25, 30, 35 and 40. What are those risk categories? If the patient has a very high risk, right, based on the history and former clinical risk assessment, the very high risk category is those have a that the patient has a mutation carrier status. Which is the mutation which is responsible for breast cancer? Yes, it is BRCA1 or BRCA2. So if the patient has a mutation status positive, or the patient has had a prior chest wall irradiation at 10 to 30 years of age, then the patient has a very high risk of developing breast cancer. We have to start immediately at 25 years. But at 25 years, mammography will not work because the breast tissue is very dense. And therefore, at 25 years, you have to start screening by using MRI. Use it once yearly for 5 years. Once the patient has reached an age of 30 years, then you can switch to mammography. Then if the patient falls in the intermediate risk category, that is, the patient has a strong family history, first degree primary relatives, say patient's mother, a sister has developed breast cancer, that contributes to a strong family history, or using some statistical models, the predicted lifetime risk of more than 20% is being calculated. Then for this category, you start screening at 35 years. At 35 years, you can do screening by using mammography, right? However, if none of these predisposing factors is present, then these patients, these women are said to have average risk, and then you start screening at 40 years. At 40 years, what modality do we use for screening? It is definitely mammography. So this is how the patients, after doing a formal clinical risk assessment at 25 years, are divided into 3 categories, and this is how screening is planned. This is something that we've already discussed in our routine videos as well. So as far as mammography is concerned, two important views are obtained. One is the craniocaudal view, the other is a mediolateral oblique or MLO view. In craniocaudal view, it is like the X-ray beam is directed from upwards, superior to inferior. The breast compression is also applied, in the superior inferior direction, right? This is something that helps us visualize the outer quadrants very well. So when you look at a craniocaudal view, you divide the right and left breast images are placed side by side for comparison. You draw a line at the middle. The upper part is the outer quadrant, the lower part is the inner quadrant. The other view is the mediolateral oblique, where the X-ray beam is directed from superomedial to inferolateral direction, and the compression is applied as shown in this image. It helps us better visualize the upper and outer quadrants. Remember, if we draw a line from the end part of the pectoralis muscle to the nipple, the part above it is the upper quadrant, the part lower is the lower quadrant, right? So this is how breast images, mammography images, are usually printed, depicted, and that is how they are reported. Two important views I want you to remember: craniocaudal and mediolateral oblique. These are the most common mammographic views which are obtained. All right. Now let's move on to the next question. I said hepatobiliary imaging is a very important topic. See, very frequently in INI-CET exams, questions on hepatobiliary imaging are asked. Identify the abnormality shown in the ultrasound image here. So what is this, right? Look at the options: Phrygian cap, Mercedes-Benz sign, gallbladder polyp, gallbladder cancer. So this is the gallbladder. The gallbladder is appearing anechoic, jet black. If you look at the shape of the gallbladder, you see something like this. So what is this? This is called as a Phrygian cap. What is a Phrygian cap? It is a cap which is worn by the residents of the country called as Phrygia, right? It was a country which existed in the olden days. Now it is a part of Turkey today, right? It is also, interestingly, a cap similar to those worn by Smurfs, if you have seen the Smurf movie, right? And this is nothing but, what is the peculiarity? Is that the cap is folded upon itself, right? So the fundus of the gallbladder is folded onto the body of the gallbladder. This is what is called as the Phrygian cap of gallbladder. This is nothing but an anatomical variant, remember. So Phrygian cap is nothing but an anatomical variant. Remember, it has absolutely no pathological significance. No pathological significance. But it has a imaging significance in the sense that it can create a diagnostic dilemma. What is the diagnostic dilemma it can create? Now, suppose that this, because of this folding of this particular fundus onto the body of the gallbladder, this part where the two walls are opposed can resemble or look like a septum within the gallbladder. It can be misdiagnosed as a septum. Sometimes if the septum becomes thick, right, if the gallbladder wall becomes thick, this may be misinterpreted as a mass lesion along the wall of the gallbladder. So imaging wise, it is important to identify a Phrygian cap because it can sometimes mimic a septum or mimic a mass lesion in the gallbladder, can lead to a misdiagnosis. And therefore, it is important to be aware of a Phrygian cap. Now, it brings me to another important, typical property of the INI-CET exams, and that is the emphasis on hepatobiliary imaging. Here in this exam, there was an ultrasound image related to the gallbladder, which was asked, right? So let us quickly review some gallbladder related spotters, right, for the upcoming exams, right? So see here. This is how a normal gallbladder would appear. So this is the liver. This is the anechoic gallbladder. Look at the jet black appearance. Why? Why is it anechoic? Because the content is bile, which is clear. It is not turbid. Look at the thin wall of the gallbladder. It is very thin. There is no gallbladder wall edema. There is no free fluid which is collected around the gallbladder. So this gallbladder is not inflamed. There are no signs of inflammation. This is how a normal gallbladder would look like on ultrasound. Now compare this gallbladder with this one. Now here we can see the liver, portal vein. Look at the gallbladder. It is still anechoic jet black. But what is there inside the gallbladder? Watch carefully. Can you see a hyperechoic area? That is a bright appearing area. And what is this? Can you see behind it? There is a dense shadow behind it. So hyperechoic with posterior shadow on ultrasound is what? It is a calculus. Yes. So this is our gallbladder calculus looks like. Remember, USG is the investigation of choice for biliary calculi or a gallbladder calculi. Why so? Because these biliary calculi have poor calcium content, and therefore if you do an X-ray or even a CT scan for that matter, because of the poor calcium content, these calculi might not be visible on X-ray on CT. And therefore if they ask you what is the investigation of choice for biliary calculi or gallbladder calculi, it is going to be ultrasound. This is an important concept I want you to know. Now, is this gallbladder inflamed? No, the gallbladder wall looks good. The content is good. Now, one fine day, this patient presents with severe pain in the right hypochondriac region. Murphy's sign is positive. Patient has tachycardia, mild fever, elevated counts. You do an ultrasound, and what do you see? Look at this. This is the liver. This is the gallbladder. Look inside the gallbladder. There is a hyperechoic area with a posterior shadow around it. So what is this? This is a calculus, but the calculus is impacted at the neck of the gallbladder. There is stasis of bile within the gallbladder. This bile gets infected. Because it is infected, it becomes turbid. So can you see all this thick sludge within the gallbladder? Look at the gallbladder wall. The gallbladder wall is thickened. Can you see these hypoechoic areas in the gallbladder wall? Yes. So there is fluid accumulation in the GB wall as well as around it. Stasis, turbid bile, GB wall edema, fluid around the GB wall with an impacted calculus. Patient is presenting with pain and Murphy's sign positive. What is your diagnosis? The diagnosis is acute calculus cholecystitis. So can you see the spectrum of findings related to the gallbladder? A normal gallbladder versus a cholelithiasis or GB calculus versus cholecystitis due to an impacted calculus, right? So this is a very excellent series of comparative images. We have done a comparative assessment here, progressing from normal to a non-obstructed calculus to an obstructed calculus with a inflamed gallbladder. Now let us look at few more gallbladder related lesions. Look at this now. Look at the gallbladder. See, this is the liver. This is the gallbladder. Look at the wall of the gallbladder. Can you see some echogenic lesions? Yes, I can see 1, 2, and 3 echogenic lesions. Now look at these echogenic lesions very carefully. I want you to note that here there is no shadowing at all, right? So these are not calculi. In the previous slide, when we saw calculi, they were echogenic foci with deep, dense posterior acoustic shadowing. Here there's no shadowing. And though this lesion is on the dependent side, can you see that this lesion and this lesion are in the non-dependent wall of the gallbladder? So it is something arising from the gallbladder wall, which is not a calculus. What is this? These are small growths arising from the gallbladder wall. This is how is the appearance of gallbladder wall polyps. So echogenic lesions, even in the non-dependent walls, without any shadowing, these are gallbladder wall polyps. All right. Now look at another classical appearance of the gallbladder. What do you see? This is the liver, this is the gallbladder, and look at the thickened wall of the gallbladder. What are all these called as? Can you see multiple of them? These look like comet tails, isn't it? So this is what is called as the comet tail appearance of the GB wall, and this is a feature of adenomyomatosis of gallbladder. So comet tail appearance along the GB wall is a feature of adenomyomatosis of gallbladder. Remember, in this condition, there is an hyperplasia of the GB wall, and there are multiple sinuses that develop within this GB wall. These are called Rokitansky-Aschoff sinuses. There are crystals which get, trapped within these sinuses, and these crystals give rise to this comet tail appearance of adenomyomatosis of gallbladder. So multiple gallbladder related spotters we have discussed here. Now let us move on to the next question. Right now, look at this particular question. An MRCP image, hepatobiliary imaging, I have already told you, is a favorite topic for your INI-CET exams. Second question on hepatobiliary imaging, an MRCP image is shown here. Which among the following is the most likely diagnosis? Now, what is an MRCP? MRCP is magnetic resonance cholangiopancreatography. How is it different from a ERCP, endoscopic retrograde cholangiopancreatography? We'll discuss that in some time. Let us right now focus on this image and the finding within it. Now, I'm sure you've seen the clinical edge videos that were published in the last few days, right? Something new that I've tried to do in these videos is to bring in a new, way or technique to look at radiological images and interpret them, and that is what I call is my magic view graphic, technique. So I was very happy looking at the response that you all guys gave me for the magic view graphics that we introduced in the clinical edge videos. So I've extended that effort, right? And here are again a few, beautiful magic view graphics that we are going to use to interpret these particular images. So what is MRCP? Magnetic resonance cholangiopancreatography, remember, are heavily T2 weighted MRI images. So, right, basis of MRI, T2 weighted MRI images, it is fluid or water that appears bright on T2 weighted images. These are heavily T2 weighted images, meaning that anything in the body that contains water or fluid will appear extremely bright on these images. Rest of the structures would appear relatively dark or hypointense. Fluid containing structures will appear bright or hyperintense. They are accentuated. Other structures are suppressed or in fact subtracted from the image. And this is how an image of fluid containing structures is obtained. The biliary tree, for example, is filled up with bile entirely, and this is a fluid containing, biliary tract or biliary tree. It will be accentuated, it will be better seen. So look at this image now. Here in this image, this is how the liver parenchyma is, or the liver as an organ is, but it has been subtracted from this particular image. So just so that it gives you a perspective, I want you to realize this is where the liver is. On the under surface of the liver, can you see an oval structure which is filled up with fluid? Can you see this? This is what? This is the gallbladder, right? Now look at something coming out from the liver. Can you see the entire biliary tree starting from the intrahepatic biliary radicals? That is the right hepatic duct, left hepatic duct, right? Look at the magic view graphics there. The bile is draining from the right and left hepatic ducts. It is coming into the common biliary duct, and the entire IHBR as well as the common biliary duct is dilated. So all the intrahepatic biliary radicals, right, left hepatic ducts as well as the common bile duct are dilated. Why are they dilated? Because can you see something within the common bile duct? A black area, well-defined focal area. What is that? It is called as a filling defect. Why is there a filling defect? Because there's something impacted within the distal CBD. What is that? This is nothing but an impacted calculus within the CBD. Look at these magic view graphics again. So this is where the liver is. This is where the gallbladder is. You can see the dilatation of the entire biliary tree, intrahepatic radicals, as well as the common bile duct. Why so? Because there is an impacted calculus at the terminal CBD, and this calculus is appearing as a filling defect. A calculus within the gallbladder is called as cholelithiasis, right? Calculus within the gallbladder is called cholelithiasis, whereas a calculus within the common bile duct is called as choledocholithiasis, right? So in the exam, a few students have said that there were multiple such filling defects. So there were multiple calculi within the common bile duct. Few students have said there was a solitary big defect. So eventually the diagnosis in the particular image which was given to you in the question was choledocholithiasis, right? So coming to ERCP, which is considered to be the gold standard investigation for biliary tract imaging. Endoscopic retrograde cholangiopancreatography is the gold standard technique for biliary imaging, and endoscopy is done, right? The gastroenterologist visualizes the ampulla of water. It is cannulated. So this is the endoscope. This is where it has the cannula was passed into the ampulla, right? And then contrast was injected. So the contrast is opacifying the common bile duct as well as the pancreatic duct. So it will help us see strictures, mass lesions, impacted calculi. Not only the diagnosis, but also the treatment is going to be possible. A sphincterotomy can be done to relieve a stricture so that the tree opens up, right? If there is a calculus, the calculus can be retrieved out, it can be removed. A stent can be placed across the CBD, so all these treatment things can also be done. But a contrast is going to be injected into the biliary tree. It is an invasive technique. X-ray exposure is going to occur. Compared to this, a better way to just image the biliary tree would be a non-invasive imaging technique, which is called MRCP, magnetic resonance cholangiopancreatography, which is considered to be the best non-invasive imaging technique. All right. So this is the difference between ERCP and MRCP. Now, MRCP, a question was asked once, a couple of years back in an INI-CET exam itself. The management related question was asked whether you do an ERCP or an MRCP. The answer in that question was ERCP. Let us discuss few conditions that can readily be diagnosed on these modalities. Let us start with some MRCP spotters. Look at this. This is the liver here, right? I say the liver is going to be subtracted. It is not going to be prominently seen. You can see the biliary tree. You can see the common bile duct. And what do you see in the common bile duct? You see a filling defect. So what is this? This is nothing but a calculus which is appearing as a filling defect within the common bile duct. So what is your diagnosis? The diagnosis is choledocholithiasis, right? So this is choledocholithiasis. Look at this MRCP image again. See, this is the liver. This is the biliary tree. This is the CBD. Can you see a filling defect within the CBD? Yes. So what is this? This is a calculus. But watch carefully. This is the gallbladder. Can you see some filling defects within the gallbladder as well? Yes, there's one here, there's one here. So there are calculi within the gallbladder, as well as one of these calculus has passed into the common bile duct. It is impacted into the terminal common bile duct. So this is GB calculi, that is cholelithiasis, along with choledocholithiasis, right? So these are a few important spotters. Now see, there are strictures. So if you look at strictures, see here, if you see a stricture which is smooth, elongated and tapering. So liver is not seen, the biliary tree is dilated, right? So this is the common biliary duct. You can see involving the mid-common biliary duct, there is a smooth, elongated tapering without any abrupt narrowing, without any irregularity. It is a stricture. It is likely to be a benign stricture. Why? Because it is smooth, because it is tapering. There is no irregularity. Whereas if you look at this stricture, right, it is abrupt. So it is not tapering, it is abrupt. There is a shouldering like effect. So this is called shouldering like effect because it is abrupt. All of a sudden, there is a sudden cutoff. And sometimes on post contrast images, there might be enhancement at the site of this stricture. Then such strictures are likely to be malignant strictures. So a smooth elongated tapering narrowing is usually a benign stricture. An abrupt shouldering like narrowing with some enhancement on post contrast images is likely to be a malignant stricture. Now look at this MRCP image. Can you see this is the liver? Look at the common bile duct. How is it appearing? It is dilated, isn't it? What is the shape? It is fusiform like this. So this is a fusiform dilatation of the common bile duct. This is a type of choledochal cyst. Do you remember? Do you remember the various types of choledochal cyst? Right? One of the most common types is a fusiform dilatation of the common bile duct. What is the type? This is called as type 1 choledochal cyst. Just involving the extrahepatic common bile duct, there is a fusiform dilatation. This is called type 1 choledochal cyst. Look at this liver now. On this MRI image, inside the liver, you are able to see multiple cysts. Most of these cysts show a central dot. Can you see that? Most of these cysts show a central dot. A vessel is passing through it. So this is a choledochal cyst which involves the intrahepatic radicals. A vessel is passing through it. This is called a central dot sign. This is type 5 choledochal cyst. I'm giving you a clue. Can you tell me what the diagnosis is? Type 5 choledochal cyst is called Caroli's disease. And this dot that you see within it, this is what is called as the central dot sign of Caroli's disease, right? So this is how the appearance is. Now we come back to this image. We have already seen this is where the liver is going to be, right? So this is where the liver is going to be here like this. I'm going to start with this slide again, team. I'm going to start with this slide again from this point. Now let us come back to this question. We've already seen this image, right? We saw the magic view graphics. This is going to be the liver. This is going to be the gallbladder. These are the intrahepatic biliary radicals. This is the common bile duct, and there is an impacted calculus there which appears like a filling defect. So the diagnosis here is going to be choledocholithiasis. We've already seen this using the magic view technique as well. Now look at this chest X-ray basics question. Identify the fracture site in the X-ray shown below. So they are telling you that there are fractures. You have to identify where the fracture is. This question is based on a very, very important topic which is based on the basics of chest X-ray. And what is that? It is how to identify ribs on a chest X-ray. So how to identify ribs on a chest X-ray? Let us have a look. See here. So if you look at the anatomy of the rib, let us quickly revise the anatomy of the rib. Rib has a round head. This round head of a rib articulates with two hemifacets on lateral surface of the thoracic vertebral bodies that form a complete facet. The round head of a rib articulates with it just besides the vertebral column or the vertebral bodies. That is how a rib begins. Then the rib goes laterally. It articulates with the tip of the transverse process. Then the rib goes around the chest. It comes anteriorly. Anteriorly, remember, most of the bony ribs end away from the sternum. There is a gap between the sternum and the anterior ends of the ribs. This gap is bridged by costal cartilages. So, if you know the anatomy of a rib now, can you tell me which end of a rib is more closer to the midline of the body? Is it the posterior one or anterior one? It is definitely the posterior one. So remember, based on location, posterior ends of ribs are closer to midline because that is how the ribs begin anatomically, whereas anterior ends of ribs are away from midline. Now see here, all these ends of ribs that I'm drawing here, they are all closer to midline. Can you see that? So these are all posterior ends. Let us trace any one of these ribs now. Let us trace this rib. See, this rib goes like this, like this, like this, like this, like this. It comes here, right? So look at this end of this rib. This end is away from midline. So this is definitely the anterior end. So can you see this in this image? Posterior ends of ribs are closer to midline, anterior ends of ribs are away from midline. Another way to distinguish between them is to look at their direction or orientation. See, as I've drawn these red lines here, can you see most of them are horizontally oriented like this? Can you see this? So most of them are horizontally oriented. So posterior ends of ribs are predominantly horizontal in their orientation, whereas anterior ends of ribs, now see all these anterior ends of ribs, can you see, right? See all these anterior ends of ribs, right? They are obliquely oriented like this. So all the anterior ends of ribs are obliquely oriented. So let us summarize. Look at this image now. All the posterior ends of ribs are closer to midline and horizontally oriented. All the anterior ends of ribs are away from midline and they are obliquely oriented. That is how you identify which part of a rib is posterior, which one is the lateral one in between them, and which one is the anterior one, right? The lateral part is the one between posterior and anterior parts. This is important because if there is a rib fracture, you must be able to localize the fracture. Which rib is involved? You have to count from the top. That was the question asked in this exam. Where is it? Maybe this is something that they'll ask you next time. Is it involving the posterior part of the rib, lateral or anterior one? Therefore, we must know this. Another reason why this is important is, to know or to judge whether a radiograph is a good inspiratory radiograph or not. When do we say that a chest X-ray is an adequately inspiratory radiograph? We say this when we see at least 6 anterior ends of ribs or at least 10 posterior ends of ribs above the diaphragm. Above the diaphragm. So when we see 6 anterior ends or 10 posterior ends of ribs above the dome of diaphragm, then we say it is an adequately inspiratory chest radiograph. Now look at this chest radiograph. Let us count the ribs now. See, this is the first rib. So this is the second rib. This is the third rib. So this is 1, this is 2, this is 3, So this is 4, this is 5, this is 6, this is 7. I'm just drawing the posterior ends now. This is 8, this is 9, this is 10. Right? So if you see which rib is fractured, this is the 6th which is fractured here. Can you see there is a step off there? And this rib is also fractured. So this is the 7th one which is fractured. So which rib is fractured here? It is the 6th and the 7th rib which is fractured here. That is going to be the answer to this particular question. A few students have said it was the 4th and the 5th which was, fractured. It doesn't matter really what the exact rib which was involved there, as long as you're able to pick up which rib is. You have to count it from top to the bottom, and you must be able to identify which one is the posterior part, lateral part, anterior part. Here it is predominantly the posterior part of the rib, or the posterior mid part of the rib which is fractured. So this is 6th and 7th rib which is fractured. All right, so this was about rib fractures. Chest X-ray basics is very, very important for all your exams, not just for INI-CET, right? So this was the question on chest X-ray basics. Now let us look at this particular image. A patient presents with dysuria, right, and pain in the back. His lumbar spine X-ray is shown below. What is the diagnosis? We'll come to the options. We'll discuss the question in some time. Let us focus on this image first. So see, dysuria and pain in the back. This, especially in the summer months, right? I see a lot of patients like this every day, presenting with dysuria, pain in back. And the first thing that comes to my mind, even before I start doing an ultrasound in these images, is that probably these patients have renal calculi or say nephrolithiasis, right? So in this X-ray, you have to focus on the kidneys. So let us use some magic view graphics here as well. So look at the kidneys. So this is how the kidneys are appearing. I've just highlighted the outline of the kidneys. Can you see that? And there's something dense that we are able to see within the kidneys. Does it look like nephrolithiasis? Are these focal calculi within the kidney? No. In fact, it appears as though the kidneys are diffusely calcified. So this is in fact calcification in the renal parenchyma. So this is not nephrolithiasis. In fact, this is nephrocalcinosis. Do you get the difference between them? Nephrolithiasis means renal calculi. Nephrocalcinosis means calcification involving the renal parenchyma. Look at the magic view graphics there. Renal outline, diffuse calcification involving the renal parenchyma. Can you see it now? Yes. So magic view graphics will help you identify the findings on images better, right? I hope you love them as much as I have loved making these graphics for you. So this is nephrocalcinosis. Let us try to see the difference between how nephrolithiasis and nephrocalcinosis would appear. Look at the first image there. Look at the graphics there. Can you see two calculi within the right kidney? One is almost at the renal pelvis. The other one appears to be in the renal lower pole calyx. Look at the second image, the big calculus, right, in the right kidney there, right, probably the upper part or the mid part of the right kidney. These are how renal calculi would look like. As against this, look at the contrast, a diffuse calcification involving the renal parenchyma. This is how nephrocalcinosis would appear. Can you make out the difference between them now? Calculi would appear as focal densities. Nephrocalcinosis is diffuse calcification in the renal parenchyma. So what could be the causes for nephrocalcinosis? So nephrocalcinosis, remember, can either be medullary type, where the calcification predominantly involves the renal medulla. This is the most common type, which is seen in almost 95% of cases of nephrocalcinosis. Very rarely, occasionally, it can be cortical type, which is around say 4 to 5% of the cases, and very, very, very rarely it can be of the mixed type. The image that we see here looks like a diffuse renal calcification involving cortex as well as the medulla. What could be the causes of nephrocalcinosis? A wide range of conditions can cause nephrocalcinosis, and interestingly and surprisingly, those conditions that predispose to the formation of nephrolithiasis, right, that is stones, also predispose to nephrocalcinosis. One very such important condition is hyperparathyroidism. say primary hyperparathyroidism, excess of parathormone being secreted by a tumor, parathyroid adenoma. Parathormone level is increased. What is the role of parathormone? It will increase the blood calcium, cause bone resorption. Excess of calcium going around in the system in the body, right? So what is going to happen? It is going to give rise to nephrocalcinosis and nephrolithiasis both, right? So one of the important causes of nephrocalcinosis as well as nephrolithiasis is hyperparathyroidism, right? Nephrocalcinosis can be seen in renal conditions like renal tubular acidosis. It can be seen in multiple myeloma. It can be seen in Barter's syndrome. It can be seen in hypothyroidism as well as hyperthyroidism. So hypothyroidism as well as hyperthyroidism, right? So all these conditions, a wide range of conditions, can give rise to nephrocalcinosis. Right, now look at this image. Now we've already discussed that the diagnosis over here is what is nephrocalcinosis, diffuse calcification involving the renal parenchyma, right? So which of these causes we have discussed is a very important cause of nephrocalcinosis? It is definitely hyperparathyroidism, because the role of parathormone is to increase the blood calcium or serum calcium, right? This excess calcium over the long term, right, is going to give rise to renal calculi as well as renal parenchymal calcification. So nephrocalcinosis as well as nephrolithiasis both, right? So the answer to this question therefore was hyperparathyroidism. Yes. Banana sign on USD is associated with which of the following conditions? See, another high yield topic for INI-CET exams is your antenatal ultrasound. So double bleb sign, right? Double decidual sac sign, anencephaly, hydatidiform mole. All these images have been asked in INI-CET exams, right? Another obstetric ultrasound based question, banana sign on ultrasound. Now let us see what normal shape of the cranium is. So I want you to focus on the shape of the skull. Look at the shape of the skull. It is oval like an egg, right? Now compare it with this shape. Now what do you see? It appears as if in the frontal part there is a pinch here, there is a pinch here, and there is a pinch here, and this shape is what is called as the lemon shaped skull. Lemon shaped skull. See, look at this shape and compare and contrast it with this shape. So I've kept these images side by side, right, above and below it, so that you can compare and contrast. Now look at the second image. I want you to focus on the shape of the cerebellum. The cerebellum has a globular appearance like this. It is like a telephone handle, telephone receiver in the olden days, right? That is how it looks like, a globular shape. Now what happens to the cerebellum here? See, in the same condition, what has happened to the cerebellum? The cerebellum has wrapped around the brainstem like this. Why? Because the size of the posterior foci is small. Posterior foci is collapsed because of the less space and decompression there. What is going to happen? Because of the restricted space, the cerebellum has wrapped around the brainstem. This appearance of the cerebellum is what is called as the banana sign. This was the question which was asked in the exam. So lemon shaped skull, banana sign. This patient, once I saw this on ultrasound, I immediately went to the evaluation of the spine. And what did I see in the spine? I saw that there was a big defect in the spine. There was a sac comprising of meninges, cerebrospinal fluid, and some neural elements projecting out through that defect. A 3D reconstructed image in the lower back is showing me that sac over here. So the diagnosis here, along with lemon-shaped skull, right, a banana sign on ultrasound, and a lumbar meningomyelocele. What is the diagnosis? The diagnosis is spina bifida, right? So there is a lumbar meningomyelocele. Why is there a lemon-shaped skull? Is because a lot of CSF is going into this sac, right? Sometimes if the sac is open, it may go into the amniotic cavity, and therefore there is a decompression, a decreased pressure, because the brain is like collapsing, right? And therefore the skull vault is also drawn inside, and this is what gives rise to the lemon-shaped skull. Similarly, as the CSF drains down through the spinal canal, out through the spinal canal, right, there is a constraint in the posterior fossa. Because of this space constraint, the cerebellum simply wraps around the brainstem. This is the pathophysiology as to why we see a lemon-shaped skull and a banana sign in spina bifida or meningomyelocele. So banana sign on ultrasound is associated with spina bifida or meningomyelocele. We have discussed what are the various signs which have been described. Yes, now let us look at this particular question. See here, a 25-year-old male who sustained a shoulder injury presented with swelling and pain at the shoulder joint. X-ray is shown below. Oh, they have not asked you what is the diagnosis on this X-ray, but they are asking you which of these ligaments would be injured. Well, to get to the ligaments, we must first know what the diagnosis is in this image, right? So let us look at a few shoulder related X-rays here, right? And I'm going to use my magic view graphics again. So look at the first X-ray image. Watch carefully. You can identify this bone. This is the clavicle. The clavicle articulates with what? Clavicle articulates with the acromion. So clavicle articulates with the acromion. This is the clavicle acromion. And how do I determine whether the acromioclavicular joint is in good alignment? I simply draw a line at their inferior edges. I draw a line at the inferior edge of the clavicle, inferior edge of the acromion. The line should be perfectly aligned, at the inferior edge of the clavicle and the inferior edge of the acromion. Then I say that the joint is well aligned. Look at the X-ray which was given in your exam. I can see the clavicle, I can see the acromion, but are they aligned? No. If I draw a line at the inferior edge of the clavicle and the acromion, I can see that there is an obvious step off, and this obvious step off is telling me that what is the diagnosis here? The diagnosis here is acromioclavicular dislocation. Acromioclavicular dislocation following trauma. There is an acromioclavicular dislocation. See, the glenohumeral joint is normal. Why? Where is the glenoid? This is the glenoid here. This is the coracoid process. This is the glenoid, and this is the head of the humerus. So the glenohumeral joint is in normal alignment, but the acromioclavicular joint is dislocated. Now, when we look at the acromioclavicular joint, remember, there are 1, 2, and 3 structures, soft tissue structures that help stabilizing the acromioclavicular joint. What are those? A ligament which is immediately adjacent to the joint. So this is the acromioclavicular ligament. A ligament, another ligament which holds the clavicle in its position. So this is called as the coracoclavicular ligament. So this is the coracoid process here. This is the clavicle. So there is a set of ligament that runs between the coracoid process and the clavicle. This is called coracoclavicular ligament, right? So coracoclavicular ligament in fact has 2 parts. One is called as the conoid part here, as you can see in this image. See, this is the conoid part, and there is a trapezoid part, which is a fan of fibers like this. So trapezoid part. So conoid part and trapezoid part are parts of coracoclavicular ligaments. And another third structure that helps stabilize the acromioclavicular joint is the insertion of trapezius muscle. Insertion of trapezius muscle, so, or tendon. So in this particular order, these are also the structures which are going to be disrupted whenever there is an acromioclavicular joint dislocation. So the first structure to be disrupted will be the acromioclavicular ligament. Now once this joint is dislocated, right, this limb will simply fall down, right, because of the weight of this limb due to gravity acting on this particular joint. So as the joint is dislocated, the scapula and the humerus is going to go down. As it goes down, the coracoclavicular ligament is stretched. The conoid and trapezoid part is going to be torn. So the second ligament to be injured is the coracoclavicular ligament. And ultimately, when there is a gross dislocation of this joint, the trapezius tendon insertion is also going to be hampered, right? So if you look at this question, see here, this is the clavicle, this is the acromion, there is an obvious step off there. So this is acromioclavicular joint dislocation. We have discussed the ligaments which will be injured in acromioclavicular joint dislocation is going to be acromioclavicular ligament and coracoclavicular ligament. This is going to be the answer in this particular question. Yes. Well, friends, we've just discussed around 6, 7 questions here, right? But there were at least around 7 to 8 more radiology related questions which were there in the INI-CET exam this time. I'm not going to waste time and discuss all of them because some of them will be discussed in pediatrics, surgery, orthopedics. So I don't want to repeat. I don't want a repetition of content here. Time is one of the most precious assets that you have, right? Remember that success is where preparation and opportunity will eventually meet. You will get an opportunity to crack your exam, right? But that will happen only when that opportunity will be met by a solid preparation that you would undergo. They say sometimes the journey, is what is the more beautiful part rather than the destination, right? We are here to make your journey to that particular destination beautiful. All of us at Team Marrow put in all our efforts to come up with all these interactive sessions, right? You have excellent video content available on the app. You have the best question bank which is available. You have schema, right? You have bookmarks, you have custom modules, you have grand tests, you have mock tests, right? You have revision videos, you have MCQ videos, right? So now that you have all the resources, right, it is an absolute responsibility on your part to give your best shot. Indulge yourself in these resources, right? Try to make this learning process as enjoyable as possible, right? We have put in all our best efforts into that, and I'm sure, right, once you start enjoying this learning process, right, you will ultimately reach that destination that you're dreaming for, and that is your most coveted post graduation seat. See you there.